Hello, everyone. Welcome back to Karan Academy. My name is Karan. I hope you all are doing super well. Today, we'll be talking about COPD. So what is COPD? So as the name suggests, it's a chronic airway obstruction because of inflammation of the small airways. And typically, that has two components. We have chronic bronchitis, bronchitis just meaning inflammation of the bronchi, and that often is characterized by a productive cough for at least 3 months each year for 2 or more years, which is where the chronic part of it comes in. And the second half of that is emphysema. Emphysema refers to permanent dilation of the air spaces in the alveoli. Now, as you know, alveoli are meant to be these really uniform grape-like sacs of air that are meant to be nice and regular. However, due to toxic stimuli, and the most common one you're going to encounter in your clinical practice is going to be smoking, we have damage to these air spaces. This often results in loss of the elastic membranes. And as you lose that membrane, they tend to balloon up. But it's important to remember, although we now have bigger balloons, these are ineffective balloons. And so even though you have dilated air spaces, you aren't actually perfusing the blood supply as it's coming through. And a picture of that is right here. So as you can see, ideally, you should have normal, well-structured alveoli with an alveolar membrane that's regular and consistent. However, with emphysema, you get these dilated, damaged alveoli that, as I mentioned earlier, are not going to be functioning at a high level when it comes to perfusion capacity. It's a very common condition affecting 13% of Australians. And the main risk factors and the biggest one is going to be smoking. Almost all of them are going to be smokers. And I'll talk about how to take a good smoking history in a bit. It's also good to ask about a family history, environmental pollution, any occupational hazards that they might have had, alpha-1 antitrypsin deficiency, because that also is associated with COPD. If they have a family history of it, although that's probably going to be a very niche condition that you might often not encounter in your practice, or have they had recent infections or tuberculosis? The reason I mentioned recent infections is because people with COPD are at a significantly higher risk of pneumonias and infective exacerbations of their COPD. And also, people who have tuberculosis chronically are at a high risk of developing COPD. So what are the typical symptoms of COPD? Being an obstructive picture, some of them are going to be quite similar to asthma. But the key differences between asthma and COPD are that asthma is reversible, while COPD isn't. COPD is going to have a more so chronic picture presenting in older patients. You're also going to have a chronic cough and sputum that's often not going to be seen as commonly in asthma. So you're going to have shortness of breath, a chronic cough, and sputum. In addition to everything we've already mentioned, some other questions that you need to ask include questions to exclude other pathologies. Now, just based on these features, shortness of breath, a cough that's been going on for way too long, abnormal sputum, you need to exclude lung malignancies. You need to exclude infections, pleural effusions, heart failures, other cardiac pathologies. When we assess severity, firstly, obviously, the first thing we're going to perform is spirometry or pulmonary function testing, very similar to what we do with asthma. The differences between asthma and COPD are, firstly, the similarities. Both of them would have an obstructive picture, meaning that although your FVC might be relatively normal, your FEV1 or the amount of air you can expel in the first second is going to be significantly less because you have an issue with the tubing system. You're also going to have minimal bronchodilator response. Why? Because unlike asthma, this isn't just a hypersensitivity issue. This is a chronic issue with established structural damage to the bronchi and to the alveoli. Some changes you might see on an X-ray include hyperlucency, which is basically decreased lung markings, because again, you have dilated air spaces. You might have an increased anterior-posterior diameter, and that's typically characterized by barrel chest, which is a sign you see on physical examination, and a flattened diaphragm, again, because their lungs are going to be hyperinflated. Lastly, you will also look out for any other signs of these conditions that I mentioned here. The classification system we use, the most commonly used one, is the GOLD system of classification, and it basically uses the FEV1 to predict the severity. Now, what's unique about classifying COPD is that it's classified based on a test, which is very, very different to the way we classify most other conditions, right? With heart failure, it's based on symptoms and what their exercise tolerance is compared to, what their exercise tolerance is to how much work they can do before they get symptomatic. Asthma classification is mostly based on symptomology, and the classification of most conditions is going to be based on symptomology. However, COPD is based on their FEV1, which is a good predictor of their severity. So mild COPD, they're going to have a reduced ratio, which is characteristic of COPD, but the FEV1 is going to be about greater than 80% of what it's predicted. Some important numbers to remember: 80, 50, 30, right? So 80, 50, 30. So if FEV1 is greater than 80, that's mild. If it's between 80 and 50, that's moderate. If it's between 50 and 30, that's severe. Anything less than 30 is considered very severe. So how do we treat COPD? The first and most important thing is going to be lifestyle changes. Please, 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 if you ever get a station or you get asked about treating COPD, and if you don't mention lifestyle changes, you are definitely going to lose out on both marks and opportunities. Smoking cessation is the biggest thing to talk about because most of your patients are going to be smokers. Now, when you come to asking people questions about smoking, you might get a varied set of responses. Because it's slightly stigmatized, people may not be willing to disclose information that's relevant to you as part of their treatment program. So a few good ways to take a good smoking history is first to always ask, well, are you currently smoking? And often their answer would be no. And you ask them, well, have you ever smoked in the past? And they say, yes, I have. Actually, I smoked from the age of 20 till 60 and I stopped last week, right? So that's obviously going to be very significant. So ask if they've ever smoked in the past. Then it's good to ask, how much did they smoke? So, well, as a rough estimate, how many cigarettes a day or how many packs a day? And a good way to then classify how many or to classify the quantity combined with the time is going to be a metric called pack years. So one pack refers to 20 cigarettes. So if someone smokes 20 cigarettes a day for 10 years, they're going to have a 10 pack year history, right? If they smoke 10 cigarettes a day, which is half a pack for 10 years, it's going to be a 5 pack year history. If they smoke 2 packs for 10 years, that's going to be a 20 pack year history, and so forth. Lastly, if they say that they've quit, and they most commonly do, it's good to ask what motivated them, because a big part of smoking cessation is going to be motivational interviewing. And it's always good to understand, well, what were their reasons for quitting? Was it more so emotion-based? Was it informative? Was it guided by information? And if so, can you help with any of that? Limiting alcohol, regular exercise is also really important. Pulmonary rehabilitation is a really, really useful occupational tool that is good in both managing their symptoms and also providing them with tools that they can use at home, or certain exercises that they can perform at home to improve their respiratory capacity. Lastly, we want to give them the annual flu vaccine and the pneumococcal vaccine because people with COPD are at a significantly higher risk for inflammatory or infective exacerbations. In fact, most exacerbations of COPD are infective based, which is why we treat them with antibiotics. In addition to these 2 vaccines, I'm sure with COVID around the corner, as always, having your booster or making sure that you're up to date with your COVID vaccinations is also really important. Apart from that, we then have medical treatment with inhalers. So let's talk a bit about that. Now, we talked about medical treatment with asthma, and our go-to standard for that was, well, baseline, everyone gets a SABA, then most patients get an ICS, then a LABA, then a LAMA. For COPD, it's the other way around. So almost all patients will get a short-acting medication for when they do act up. This can be either a SABA or a SAMA. Then when it comes to long-acting preventive medications, Again, we're going to go the other way around. So instead of going ICS LABA LAMA, we go LAMA first, then LAMA LABA, and only in severe cases do we go ICS. Now, the use of ICS has been studied quite extensively over the past few years, and they've made recommendations that ICS in patients with mild to moderate COPD has been shown to be linked with higher levels of infective exacerbations. As you can imagine, an inhaled corticosteroid, in addition to being anti-inflammatory, is also mildly immunosuppressive, which is why, unless they have severe COPD with high levels of inflammation, you should not give them ICS, which is why ICSs are last line and are only used in severe COPD. And here's another graphic just representing the same thing, again, combining the GOLD classification with some of the other things that we should look for. Across the board, you should check for device adherence, use technique, making sure that they're taking the medications at the right time with the right technique, because if they aren't, everything else you do is going to be completely useless. And then you want to keep stressing those lifestyle changes, making sure that they are not smoking. If they are, talk about what you can do, where you can help them, programs that can help them quit, nicotine replacement therapy, all good things. And then again, lifestyle choices, flu vax, pneumococcal vaccine, COVID vaccine, pulmonary rehab, and all those factors. That's all the information we had for COPD. Thank you all for coming. If you have any questions, please feel free to get in touch with me, either on my email or through Facebook. I'm always happy to answer any questions you may have. And as always, please look after yourself and please look after your loved ones.